Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an educational grant from Axum Therapeutics Incorporated.
Hello, Beth. Thank you for coming in today.
Hello, Dr. Reese. Thanks for seeing me.
So, how are you doing? Have you noticed any improvements in your mood since we increased the SSRI antidepressant dose?
I've noticed some improvements, yes, but I'm not sure the treatment is working like it should.
How so? Are you still feeling depressed? Have you noticed any side effects from the medication?
My mood seems to have gotten a little better, but I am noticing some side effects. I'm afraid I've been experiencing the sexual side effects we discussed last time. I waited a bit to see if it would get better, but it hasn't. If anything, things have gotten a little worse.
I see. Well, that's definitely something we would want to address. But you also mentioned some other symptoms that aren't improving. Can we talk a little more about that too?
Yes, of course. I'm still having trouble sleeping, first of all, and I still don't really feel like doing any of the activities I used to enjoy. Sometimes I think that's because I don't feel like I have any energy, but even if I do get some sleep, I still don't feel like doing anything I used to think was fun. Does that make any sense?
Yes, absolutely. What you're experiencing is something called anhedonia. It's the term that's used when a person doesn't feel like doing any of the activities they previously enjoyed. And along with depressed mood is a key symptom in the diagnosis of depression and in monitoring response to treatment.
I'd never heard of anhedonia before. So, if I understand you correctly, this might be the reason why I still don't feel like playing tennis with my friends or going to the gym to work out.
Yes, it might be. Anhedonia is a symptom that may sometimes get less attention when people have conversations about depression, but it's an important factor that deserves serious consideration. And if you're still not feeling up to doing any of your favorite hobbies, still not sleeping well, and experiencing some side effects, I think it may be time to discuss a different approach to your treatment.
But are there treatments that might be more effective then?
Yes. There are treatments that might decrease your current side effects and help you sleep better and feel more like participating in your favorite hobbies. Would you like to discuss them now?
Yes, please.
Hi, I'm Anita Clayton, the Wilford W. Spradlin Professor in the Department of Psychiatry and Neurobehavioral Sciences and Professor of Clinical Obstetrics and Gynecology at the University of Virginia in Charlottesville. We've seen the interview and a few things I'd like to point out about it and discuss. First is we need to be aware that the PHQ-9, which is a patient-reported health questionnaire, has all the symptoms of depression as the items in there. In addition, we need to be aware that for depression, you really have to be looking at the previous 2 weeks, and every item is rated on a score of 0 to 3. What we need to be sure is that there are at least 5 symptoms, and at least one of those must be one of the first 2. So those are the core symptoms of depression: little interest or pleasure in doing things, or anhedonia, or feeling down, depressed, or hopeless. And sometimes people have both of these. And we also have somatic or physical symptoms like sleep, lack of energy, change in appetite, things like that. And also a sense of psychological problems like concentration, uh, self worth or guilt, and potentially suicidality. She's not checking off that she's suicidal, so we don't need to be concerned about that. Her current score at this visit is 22. Her previous score was 24. So she has less than a 25% improvement in her symptoms. When you're looking at clinical trials or publications about a clinical trial, you will see the MADRS often used, the Montgomery Asberg Depression Rating Scale. And 5 of those 10 items are put together to form what's called the anhedonia subscale. And that includes apparent sadness, reported sadness, concentration difficulties, lassitude, and inability to feel. Now, the MADRS doesn't absolutely follow the criteria for DSM, but it still gets at a lot of things like the presence of anxiety, problems with sleep and appetite, and pessimistic or negative thoughts and suicidal thoughts. I mentioned that Beth's score is less than 25% improvement. And when we look at defining responses, that means she's essentially had a non response with little to no improvement. Partial response would be somebody's improvement in their symptoms that's about 25 to 49% on a rating scale, but they're still having troublesome symptoms that are affecting function. Response is actually where you see 50% or greater improvement in the scale, but they're not in remission. They still have some symptoms. We may need to add or change treatment or up the dose because residual symptoms will be much more likely to contribute to relapse. And also, those symptoms may be interfering with the restoration of functioning. So, that's really critical for full treatment of depression. And essentially, that's remission. So, remission would be virtually symptom free and normal functioning. So, we're going to try to do that for Beth.
Because your improvement has been less than 25%, I think it may be worth considering switching to a different kind of antidepressant treatment, perhaps one that is more effective for your particular symptoms.
Are there treatments that would help with this? And would they have the same side effects?
Yes, there are treatments that would help more with your specific symptoms without the sexual side effects you're experiencing now. There are actually two options I think might work well for you.
Okay, that sounds promising.
The first is a medication called mirtazapine. It works differently from the SSRI you're currently taking and may help you sleep better.
Okay, that sounds like a good option. Does this medication have different side effects?
Well, some patients notice things like dry mouth or headaches, and treatment may increase your appetite. It also might make you feel sleepy, which might be an advantage considering your sleep issues, and it does not cause sexual side effects.
And the other medication you had in mind?
The second option I'm thinking about is a combination therapy of two medicines called dextromethorphan and bupropion, which would also help address your symptoms.
And the side effects?
This treatment is associated with dizziness and dry mouth, headache, and sleepiness. We should also keep an eye on your blood pressure if you decide to start treatment with this medication.
And what are the differences between the two options? Are there any?
Well, the mirtazapine would definitely help with your sleep symptoms and help improve the anhedonia. It works fast, perhaps within 1 to 2 weeks. The combination therapy, dextromethorphan and bupropion, may work within 1 week and would help address your current symptoms as well.
I see. And the sexual side effects?
Mirtazapine has been FDA approved for decades, and there are published studies demonstrating mirtazapine is not associated with sexual dysfunction. Dextromethorphan bupropion is a newly approved medication, and we don't have studies specifically evaluating sexual dysfunction. But the sexual side effects of the SSRI you're taking should resolve with discontinuation and switching, and rapid improvement in depressive symptoms may also improve sexual functioning.
Okay. I have a few more questions if we have time.
Of course. Please ask me anything.
So I think it's very beneficial for patients to be given a couple of options and choices in terms of prescribing for their psychiatric condition. In this case, mirtazapine was mentioned. Mirtazapine works by inhibiting central presynaptic alpha 2 adrenergic receptors and increasing serotonin and norepinephrine release in the synapse. It's important to share this kind of information with patients. And one of the things that might be said is this is not a serotonin reuptake inhibitor, just so that they understand it's acting differently. Peak plasma concentrations are attained pretty quickly at 2 hours, and clinical studies really show improvements in sleep. It specifically decreases sleep latency and increases sleep efficiency. And we see reduced depressive symptoms and anxiety, often within the first 1 to 2 weeks of treatment, if we've started at a therapeutic dose. This would be a good option for Beth because we would want to improve her sleep. Sleep it improves everything, whether it's our attitude or irritability or depressive symptoms. The other option is dextromethorphan bupropion, which is a combination medication contained in a single pill. The mechanism of action of dextromethorphan bupropion combination is different from any other oral medication on the market. It modulates glutamatergic signaling via NMDA receptor antagonism and sigma 1 receptor agonism. That means it activates a protein that enhances synaptic plasticity, reduces neural inflammation, and regulates calcium signaling. We've been trying to target plasticity and neuroinflammation with our medications. This one has a much more likely chance of acting in that system. And the glutamate activity, which is the most common excitatory neurotransmitter in the brain, can also work to enhance that plasticity. The mechanism of action of bupropion is a dopamine norepinephrine reuptake inhibitor. It really helps in this case because it's also a strong inhibitor of the CYP450-2D6 system. And that increases dextromethorphan levels because it's metabolized by CYP450-2D6. And it prolongs the dextromethorphan levels so you don't have to take it repeatedly through the day. That way, we can keep low doses of dextromethorphan so you don't have some of the potential problems with high doses of dextromethorphan, which is things like hallucinations or other sort of psychoactive effects. We don't see this with the combination of dextromethorphan and bupropion as is approved. And clinical studies show a rapid improvement in depressive symptoms literally by week 1. And you're increasing the dose in that first week too. So it really does work very quickly. It shows a significant improvement in the MADRS 6 core symptoms of apparent sadness, reported sadness, inner tension, lassitude, inability to feel, and pessimistic thoughts. Why would this be a good option for Beth? Fast acting, working in a different system than our current monoamine active antidepressants. And it tends to then increase energy and improve depression very quickly. So, just to talk a little bit more about the dextromethorphan bupropion combination that we can share with patients, is it's used in many over-the-counter cough and cold medicines. In fact, many of those are locked up and have to be asked for, though, because dextromethorphan is commonly abused because of its euphoric, hallucinogenic, and dissociative properties. So, depending on the amount ingested, which may be quite high in patients who are using or abusing it for those euphoric properties, dextromethorphan toxicity can have a wide range of adverse effects. Cardiovascular effects like hypertension and tachycardia can occur, neurologic effects like psychosis, coma, and seizures, and musculoskeletal contractions leading to rhabdomyolysis. Bupropion, though, dramatically increases the bioavailability and the half life of dextromethorphan, so we can use much lower doses of dextromethorphan in this combination. Also, we need to be aware that patients and providers should not try to do it yourself in terms of creating a combination of dextromethorphan and bupropion. These are very proprietary amounts and doses, and you will have no idea whether that's what the patient is getting if you try to add dextromethorphan and bupropion that's off the shelf together. Most common side effects of the FDA approved dextromethorphan bupropion combination are dizziness, nausea, headache, somnolence, and dry mouth. The most common side effects of mirtazapine are sedation, increased appetite, weight gain, and dry mouth. But unlike SSRIs and SNRIs, mirtazapine is unlikely to cause sexual dysfunction or GI side effects. So, for a patient who's having trouble sleeping, that sedation effect would be positive for them. If they've lost a lot of weight with the depression, then a potential somewhat increase in appetite and potentially regaining that weight, which should happen when we treat the depression anyway, may be a benefit.
I'd like to ask more about the combination therapy you mentioned. What was it?
Dextromethorphan and bupropion.
I feel like I've heard of dextromethorphan before. Is that possible?
Yes, it's a common ingredient in cough syrup, so you may have indeed seen it before.
That's right. I knew I'd heard of it. But mm, I hope this isn't a silly question, but what's the difference between the dextromethorphan in cough syrup and the medication we're talking about?
Well, that is an excellent question, and I'm glad you asked. The dextromethorphan in the cough syrup is used by the body much more quickly and is short acting and has a different dosage. The main difference is that the medication we're discussing is combined with bupropion, which helps slow down how rapidly dextromethorphan is processed in the body and allows it to act on the brain receptors to help manage depression.
But couldn't I just combine the cough syrup I have at home with bupropion?
Oh, no, I'm afraid not. The combination therapy of dextromethorphan and bupropion is specifically formulated to help patients safely manage their depression. Taking dextromethorphan as an over the counter option for depression treatment increases the risk of adverse events and may result in hallucinations, misuse, and overdose. High doses of cough syrups may also result in possible organ damage since they usually contain other medications such as acetaminophen or antihistamines.
Oh my, I hadn't thought about that, but of course it makes sense.
Yes, that's why it's important to have a prescription from a medical professional for dextromethorphan and bupropion in the improved combination.
So the bupropion is what makes the dextromethorphan effective for treating depression. That makes sense now. And the other medication, mirtazapine, can it be taken by itself without another medication?
Yes, mirtazapine can be taken as a monotherapy and doesn't require a combination with another treatment. We would start at a low therapeutic dose, which we can increase later if we need to.
And both of these medications are pills I can take? And how often would I need to take them?
Yes, both medications are available as a pill and can be taken once a day. It might be best to take the mirtazapine before bedtime, though, as it may make you sleepy.
Okay, this is all really good information to have. Can I think about it for a little bit and let you know which one I would prefer?
Of course. Let's meet again in a week or so to discuss your decision, and you can contact me if you have any questions in the meantime, okay?
Yes, thank you. I appreciate that.
All right.
So, when we're thinking about what we'd like to recommend to the patient, we need to make sure that we have a strong therapeutic alliance and help the patient understand the range of therapeutic options. because we want to have shared decision making. We want to know what the patient preferences are. Do they want to avoid sexual dysfunction? Do they want to avoid weight gain? Are they worried their anxiety may be increased? Things like that. We want to find out what they really want in the next treatment, and are they willing to take a different medication? We also want to know about lifestyle factors. So we want to know about their sleep. We want to know about exercise. We want to know about nutrition. Things like that may also play a role and tells us a bit more about the patient. Same with their psychosocial situation. But we also want to talk about prior treatment tolerability and what we might expect with what we're going to offer. And so if they understand the options, and I usually want to give them two options, and I essentially say, okay, let's choose what we want to start with. And if this doesn't work out for some reason, we can go to the other option. And that's reassuring to patients that we're anticipating should something else need to be done. We want to then agree that they want to take medications and that we're going to switch, and we explain our recommendations and why we would be recommending them for that patient. And then they select which one they want to start with, whatever aligns with their values, what they feel they need, what makes the most sense to them. And in this case, the difference would be a known drug, mirtazapine, which has been around for a long time, and the dextromethorphan bupropion combination, which is new but works on a different mechanism in the brain. So it may be helpful in someone who did not respond to, for example, a serotonin reuptake inhibitor and acting in that system. The patient and the clinician both should contribute equally to this decision making process, and everyone is on board for taking it, adhering to treatment, and letting the provider know if there is a problem that comes up in the treatment. That way, we can ensure that the patient is more likely to take a dose that is potentially effective and hopefully will be.